Patients presenting to the primary care physician or emergency department with lower extremity symptoms suggestive of venous thromboembolic disease require a diagnostic evaluation. It is important to rapidly diagnose DVT, allowing for immediate treatment with the reduced chances of pulmonary embolism. Although contrast venography was the diagnostic standard, this has largely been replaced by ultrasound as the first-line imaging modality. The accuracy of examinations increases with increased clinician ultrasound experience and training. With a handheld ultrasound device, we will visualize the entire deep venous system from the inguinal region to ankle. Catherine Eller, senior sonographer at a private radiology clinic in Australia and lecturer and tutor for emergency medicine courses, will guide you through this lecture and will demonstrate how to perform a DVT exam with a handheld ultrasound device in the primary care setting.
In this lecture, I will be covering basic anatomy, risk factors and causes of DVT, ultrasound appearances and scanning techniques for the lower limb. In addition, live scanning will be performed to emphasise your learning experience from this lecture. DVT ultrasound has many advantages in a point-of-care setting. We want to rule out the lower limb DVT in order to reduce the risk of a pulmonary embolism and reduce the morbidity and mortality. It's very portable, we get an immediate result, and of course there's no radiation risk. In point-of-care ultrasound, we need a rapid and accurate diagnosis for patient care. Ruling out if a DVT is present is important also to reduce the risk of a pulmonary embolism. Deep vein thrombosis, which embolizes, is a common cause of morbidity and mortality in patients who are critically ill. Studies have demonstrated that 2D imaging alone with compression has an accuracy similar to utilising colour and Doppler ultrasound. Some point-of-care DVT examinations only focus on the deep veins from the common femoral vein to the distal popliteal vein, as the incidence of below-knee DVT embolus is rare. It also takes a very experienced operator to accurately assess the small veins of the calf. In this tutorial, I will endeavour to give you a step-by-step approach to imaging the veins of the leg from the common femoral vein in the groin to the popliteal vein at the knee. And here are some of the risk factors you can see here. Recent trauma, recent surgery, especially knee and hip surgery, obesity and cancer. The clinical signs of a DVT patient presenting to you in your department include swelling of the affected leg, pain in the affected leg, redness or discoloration of the skin. But as we know, DVT can also occur without any of these symptoms. Clinical signs and symptoms of a pulmonary embolism as the primary symptom occur in 10% of patients with confirmed DVT. These include sudden shortness of breath, chest pain or discomfort that worsens when you take a deep breath or when you cough, feeling lightheaded or dizzy, or fainting, also coughing up blood. Other causes of DVT patient symptoms include lymphedema, hematoma, a tumour, possibly in the pelvic region, which might be compressing the iliac vessels and causing that edema in the leg and swelling. Baker's cysts, also the symptoms of a Baker's cyst can mimic a DVT, and any aneurysm. The nomenclature of the leg veins changed many years ago so that the superficial femoral vein, which was the deep vein, is now the femoral vein, and the long saphenous vein is now the great saphenous vein. Just be aware that in some literature, people still refer to the deep system as the superficial femoral vein, when in fact it should be just femoral vein. On the left, the images depict the cross-sectional area of the changing venous anatomy as we scan distally from the common femoral vein to the popliteal vein. I have also included a list of suggested imaging acquisition planes as we see here. So coming from the common femoral vein to the saphenofemoral junction, the profunda vein, femoral vein in the proximal, mid and distal portions, and the popliteal vein. I think it's really important for us to discuss the formation of thrombus. It forms at the level of the valves and then progresses. Sometimes we see a free-floating edge in the acute stage, as we can see here. The thrombus too can differ in the acute or chronic stage and also display differing ultrasound appearances. In the acute stage, we may see a dilated vein, hypoechoic thrombus, whereas in the chronic stage, we may see a smaller calibre of vein or the presence of collaterals, and the thrombus itself may be quite echogenic. Next, we'll discuss the ultrasound appearances of the normal vein. The veins are typically thin-walled, compressible. We use the transverse plane to compress ideally, and we will discuss why we use transverse rather than a longitudinal plane when we're doing our demonstrations later. We can get spontaneous, augmented or phasic flow in our veins. We often see valves, and we know that the direction of the flow in the vein is toward the heart. The arteries are typically thicker walled, non-compressible, unless they're very small, so be aware that you can compress an arterial wall in the smaller vessels of the leg and arm. In the artery, we typically have a pulsatile flow. There are no valves visible, and the direction of the flow, as we know, is away from the heart. So why do we have to compress the veins during this examination? If a thrombus is present, hypoechoic or echogenic material is visualised within the lumen. The presence of thrombus will show no compression is possible, or perhaps a partial compression during compression of the vein with the transducer, and depending on whether the thrombus is acute or chronic. Now we'll discuss the patient positioning for scanning for the DVT examination. If possible, raise the patient's head slightly to allow the vessels to fill and distend more, which of course will help make them easier to see on ultrasound. Roll the patient slightly toward the affected side and place a cushion behind their back for support. This brings the leg naturally into an externally rotated position and allows us to image and compress the femoral vein more easily. Tuck a towel into the underwear at the groin crease, place some gel at the medial aspect of the thigh and spread the gel down to the lower thigh, ready for scanning. In a transverse plane with the transducer vertical to the skin at the groin crease, identify the femoral artery and vein. A tip for beginners is to feel for the femoral pulse, then place the transducer directly over it. The artery and vein will appear as two anechoic circular structures side by side. You can see more than two vessels in the image, then you are too low and need to slide the transducer more cephalically. Adjust the depth and gain, and then use firm downward pressure to bring the walls of the veins together. If the walls do not coapt, then you either have not compressed firmly enough or there is thrombus present. If the artery is beginning to compress, then you're probably putting too much pressure on the vessel. Once you have compressed this level of the common femoral vein, slide the transducer caudally to the saphenofemoral junction. Unless the patient has had their great saphenous vein stripped, you will see the Mickey Mouse sign, or what we call the Mickey Mouse sign, as you can see here depicted on this image. So we've got the common femoral vein as our Mickey Mouse head, our common femoral artery as our ear, and the great saphenous vein as the other ear. The great saphenous vein should also be compressed for a short segment. Even though this is considered a superficial vein, it's still going to be part of the deep vein examination. We need to exclude a thrombus at this point, as there's a high probability that it might extend into the deep system if it's within 2 centimetres of the saphenofemoral junction. So now we're going to keep the transducer vertical to the skin as you slide down the thigh, compressing each centimetre. Here on this image here, you can see the artery and vein at the proximal thigh, and with compression on the right, we have the artery only visible now because the walls of the vein have coapted completely together, showing there's no signs of thrombus in this patient. As we come to the mid and distal thigh, the compression technique becomes more difficult and can often be quite painful for the patient. To assist easier compression, place your left hand behind the thigh at the level of the transducer and push upward toward the transducer as you are compressing down with your right hand. This is literally sandwiching the vein between the muscle bellies of the thigh. Continue compressions to the distal thigh until you can no longer clearly visualize the vein. My personal suggestion is that it's about a hand span from the level of the superior border of the patella. On these images here, we can show the artery and vein here on the left, and in the image on the right, we've compressed the vein now and only leave the artery visible. We can definitely say there's no thrombus visible in that vein at that point. Now move the transducer to the popliteal crease and adjust the depth and gain again to optimize the image. In the images here, you may also see not only the common femoral vein and artery, but also the branches of the popliteal vein. For example, we've got our gastrocnemius and our soleal and our short saphenous veins here. On the right-hand side, all the veins have compressed and only the arteries remain. Continue your compressions cephalically to overlap at the level of where you ended your medial scanning of the deep femoral vein. You can slide back to the knee crease then and continue compressing the popliteal vein caudally until it divides into the tibio-peroneal trunk. This has now completed the above knee DVT study. Now we will move our transducer to the medial aspect of the mid-calf using the tibia and fibula as our bony landmarks to identify where the posterior tibial veins and peroneal veins lie in the leg. The veins are paired running alongside the artery in the lower calf, with the posterior tibial veins closest to the tibia and closer to the transducer, and the peroneal veins are closest to the fibula and further away from the transducer. We'll slide this transducer superiorly with compressions every centimetre once again to the tibio-peroneal trunk, then slide inferiorly with compressions to the ankle. To assist with compressions, you can use the other hand to sandwich the veins between the muscles, as we did in the lower thigh. Now to scan the anterior tibial veins using the anterolateral approach with the transverse transducer between the tibia and fibula, using these two bones as our landmarks. Find the anterior tibial veins between these two bony landmarks and compress from proximal to distal lower leg. This image here is a suggested transducer position to image the calf veins. Sometimes we may see them from a medial approach, as in here. We may see them from the posterior or lateral approach. We'll also see the anterior tibial veins from our anterior approach. And again, in the mid to lower calf, we may change slightly our transducer positions and see the peroneal and posterior tibial veins in one view. And if we're struggling to see those peroneal veins down here, we might come from the posterolateral approach as we could do here. Some takeaway scanning tips to remember. Always compress in transverse, not in a longitudinal plane. Don't mistake the profundal vein for the femoral vein. You should only see a short segment of this profunda vein unless there's been a prior chronic thrombus, and then the profunda vein may be slightly enlarged. There is often duplication of the femoral vein at any level of the thigh, and then it can re-enter also at any level of the thigh, sometimes into the popliteal vein. When the 2D imaging is suboptimal, especially in the adductor region, we can utilise colour Doppler to help fill the vessel and exclude occlusive thrombus. A non-compressible vein may be mistaken for an artery, leading to a false negative result. An artery may also be mistaken for a non-compressible vein, leading to a false positive result. Large superficial veins may also be mistaken for deep veins, especially in patients with a large body habitus. In the next part of this lecture, I will perform some live scanning with a handheld ultrasound device to demonstrate and reinforce the scanning techniques we have just discussed. So now I'm going to demonstrate how I perform a DVT examination for the lower leg. We'll start with the patient obviously in the supine position, and we're going to ask the patient to roll slightly towards their affected leg, which in this case is the left leg. So we'll ask the patient to do that now, placing a little bolster under their hip and lower back just to rest and keep them comfortable. This position gives a natural external rotation of the leg in order for us to easily compress that femoral vein and make it a much more comfortable position for the patient. Now we're going to prepare the leg ready for scanning. So we'll take the gel, place a small amount on the inner thigh, take our handheld device. It's already been selected for a vascular preset here. So our linear transducer is already selected. We're going to spread the gel. Imagine where the vein is lying in the leg. So it's in behind the femur. We're going to go from the common femoral vein right down to the adductor region. So we're ready to go now. We're going to place the transducer in a transverse plane at the groin crease and look to see if we can find our vessels on the image. If we need to, we can adjust the gain and the depth. So I'm just adjusting the gain here, and now I can see the vessels. There are more than 2 vessels I can see on the image here, which means I'm slightly too low in the leg. I want to start at the common femoral vein above the saphenofemoral junction. So I'm going to slide up until I just see the 2 vessels there. Now I have the common femoral artery on the right of the screen and the common femoral vein on the left. Now I'm going to use a downward compression to compress the common femoral vein and release. I've already proven there's no DVT or thrombus at that level. So I'm going to slide slightly down from there, about a probe width, and I can see a vessel here coming off the common femoral vein, which is our great saphenous vein at the saphenofemoral junction. I'm now going to compress again, making sure the walls of the veins coapt completely to exclude the DVT. Now we'll slide even further down from the groin and continue our compressions all the way down to the adductor region. I don't know if you can see on this image here, but we now have 3 vessels visible. I'm going to adjust the gain slightly. Now when I compress, you can see there's 2 round circles compressing. This is what I was talking about in the lecture. Sometimes we have a duplication of the femoral system, and that's where we can see that at the moment. We'll continue on down the leg until we get to the adductor region, compressing as we go, every centimetre. Now we're going to continue down to the adductor region by putting our transducer on the lower leg here, placing our handheld system on the patient or on the bed. I need my left hand free now so that I can place it under the thigh. And what this is going to help me do is to compress the vein from posteriorly. So find my vein again, and I'm going to push up with my hand as well as down with the transducer. Remembering I was saying that's helping to sandwich the vein between the muscle bellies. Without the hand there, sometimes the patients find it very uncomfortable because we have to press a lot firmer without the hand behind the leg, especially in those patients that have a lot of pain or they may have some cellulitis in the leg. So once we've come down as far as we can, seeing our veins compress, I use the tip of a hand span above the knee. That's about the level of the adductor where we start to lose the image or lose the veins from the image. Keep that level there in mind as we now go posteriorly into our popliteal fossa region and place the transducer now in the popliteal fossa at the knee crease. Fanning the transducer or tilting the transducer up and down to get 90 degrees to the vessels to image them clearly. I'm also going to change the gain setting so I can see the vessels a lot clearer. And here I'm going to compress. Again, we can see more than one vein compressing in this view, and that's because we have the gastrocnemius veins and the soleal veins coming off at this level. They're all compressing and just the artery is left. Now I'm going to slide up, back up the thigh, compressing as we go, so that we come to that same level that we came down to before. And we've overlapped there and we've completed our DVT study. And now we're going to ask the patient to roll into a prone position. This will allow easier access to the popliteal fossa if you're finding this position a little bit too difficult. So now we have the patient in a prone position with a towel rolled up under the ankle. If we have the leg extended completely like this, the veins automatically compress in that position. So it's a good idea just to have slight elevation on that leg to allow us to see the veins much easier behind the knee. We'll place a small amount of gel behind the knee once again. Now we'll take the transducer with the marker end towards me in a transverse plane. Spread the jelly around, place it at the knee crease, and look for one of our bony landmarks. On the right side of the monitor, you can see one of the bony landmarks, which is our medial condyle of the femur. So I'm going to slide laterally, and there I can see my lateral condyle of the femur. And you can see the artery pulsing nicely just in the middle of the screen now. I'm going to adjust my depth first, a little bit less depth. And the next thing, adjust the gain slightly, increasing it. Now I'm going to do some downward pressure on the vein to compress it, and you can see it's sitting on top of the artery there. As you can see on top of the artery, there's a number of vessels apparent. This is because the popliteal vein now has some of the branches coming off, which may include the short saphenous vein, the gastrocnemius or soleal vein branches. They're all compressing nicely, so we're going to make our way cephalically, compressing as we go. Again, you can see the vein there coming now side by side next to the artery. Once we get to a level that's about a handspan above the knee crease, we know we've overlapped from our medial scanning aspect. So we've pretty much covered the entire femoral vein to popliteal vein region. Coming back to the knee crease, we can now continue down the leg, compressing as we go until we no longer see clearly the popliteal vein. We know that this is about the level of the tibio-peroneal trunk where the small calf veins start to branch off. And again, you can try using the handspan below the knee crease as a guide to how far down you can see those vessels well from the posterior approach. In order to see the calf veins more easily, I've repositioned the patient with the back of the bed slightly upright. This will help the veins to fill with more blood and hopefully make them a little bit easier to see. You can also have the patient sitting on the edge of the bed with the legs hanging over the side. This will also help to fill the veins better. So we'll place some jelly again on the lower leg, on the inside of the leg. Spreading the jelly from the proximal medial calf down to the ankle. We're going to place the transducer mid-calf in a transverse plane. I usually find it easier to find the veins at this position rather than more proximally, where the calf is a bigger diameter and the veins are deeper. So if we start mid-calf, some of the landmarks that I may use to find the veins, if they're not instantly appreciated, is to scan towards the tibia, which we can see here on the right of the image, the echogenic bony cortex with a shadow behind. Then we're going to slide slightly posteriorly and we'll identify the fibula at the lower part of the image. Our peroneal veins are paired against the artery, so we see the two peroneal veins here deep in the image, and our posterior tibial veins are sitting closer to the transducer here under the fascial plane here. Rocking the probe or tilting the probe up and down, we can see the veins stand out when we're 90 degrees to them. From here, I'm just going to do a compression to show you how they wink at us, and then the two arteries are now visible. Uncompress and you can see the veins refill. We're going to use the same technique as we did for the upper thigh, which is scanning each centimetre, compressing as we go. As we come to the proximal thigh, we will see the veins now merging together at the tibio-perineal trunk. This is the region that we scanned to the popliteal region earlier. Now I'm going to come back to my mid-calf and continue down the calf, compressing as I go. Again, seeing the posterior tibial veins and the perineal veins compressing until you can no longer visualise them. Even though our gastrocnemius veins are not typically part of our DVT study, a patient presenting with pain in the calf can also indicate they may have thrombus in those vessels. So if you place the transducer in the proximal calf region here, posteromedially, within the muscle belly here, we're going to see if there is any thrombus in these gastrocnemius veins, again just by compressing to make sure that the veins coact. This concludes our medial access to our calf veins, and now we're going to reposition the patient to look at the anterior tibial veins. We've repositioned the leg now so we can access the anterolateral part of the leg. This way we can view the anterior tibial veins. Another little bit of gel down the leg. Again, placing the transducer into a transverse plane and spreading the gel down that area of the leg. Again, starting about mid-calf so that we image the tibia as our landmark. Here you can see this on the left side of the screen, and then slowly slide laterally to visualise the fibula here at the bottom right of the screen. Between those two bones we have this echogenic fascial plane where the anterior tibial veins and artery are sitting directly on top of it. I'm just going to slide up the leg slightly until I can see the widest, most distended part of the anterior tibial veins, which we can see here. Compression, and you can see the two tiny little veins there compressing on either side of the artery. We're going to continue our compressions as proximally as we can here, and then distally, again compressing every centimetre along the way. The veins get very small here down at the ankle, so we might stop about this position here. So now that concludes our entire left leg DVT study from the groin to the ankle using 2D compression imaging. In summary, we covered important anatomy and scanning techniques of the deep veins of the legs. Now that you have been provided with this knowledge, I trust you can confidently perform an ultrasound to exclude or diagnose a DVT. We trust that your decision-making for the ongoing care of your patient and treatment will be made with more confidence.